Thank you very much, Kath and Ian. I must say that it's a real sort of privilege for me to come to sort of forums like this, because for those of you who don't know, I actually work in intensive care in acute hospitals. And when I was young, I was very, very interested in my ability to keep people alive. I love the machines and that sort of thing. But it soon became clear that about 1/4 of my patients died. And this is about 30, 40 years ago. Many of my patients then were very young with trauma, severe infections, after cardiac surgery and whatever, but that's all changed. Most of my patients these days are elderly in the last few days of life. And so that's a sort of theme that I'm going to be talking about. Death is the most common health event that there is, and it's really good that we're beginning to talk about this issue, death and dying. This is going to obviously increase, and unfortunately more than 70% of Australians want to die in the community at home, and by 2030, if we keep going on the way that we are, less than 10% will die at home, and more than 90% will die in institutions and in intensive care units like where I work. It's actually even worse in America, where 70% of those people want to die at home. More than 75% die in medical institutions, and because it's a fee-for-service health structure, more than 30% spend at least 10 days in intensive care because of the perverse incentives of doctors are paid for doing things. So of course, if that's how you pay off your home and send the kids to college, the more things you do, the more you're paid for it. And as a result, more than 30% of those 30% become bankrupt in the process. The last 12 months, and there's been some really good sort of data on this lately, in the last 12 months of life, and Andrew sort of alluded to this, that that in patients suitable for intensive care, 96% spend some time in hospital. So almost everyone in the last 12 months of life spent some time in hospital. At least 70% visited the emergency department at least once, and more than 60% were in hospital on the last day of life. And this is becoming worse and worse. And so someone mentioned that death has become medicalized, just like birthing was in the 1950s. And it's no one's fault. It's not some, it's not some sort of complicit sort of strategy. It's something that none of us wants, but it's just happened. And we all need to think about that and think of other ways of doing things. So this is where I work, in intensive care, surrounded by lots of machines. It costs $4,000 per patient per day. In 1980, I had 6 beds, and last year they gave me 60 beds, costing more than $1.5 million per year to operate. And the area where I work, Liverpool and Campbelltown, many people survive on $300, $400 a week for 30, 40 years, and then suddenly in the last few days of life, they come into my intensive care, no questions asked, open checkbook, and they get money that they've never seen in their life before. So in the United States, 20% of all deaths occur in ICU, and that's increasing. And as I said before, most people would prefer to die at home. So how does this happen? Well, it's sort of predictable in one way, in that if you get sick now, as opposed to, say, the 1950s when my grandfather first died, if you get sick now, then most of us would call an ambulance, because getting really sick is frightening. And I'd probably do the same, because you don't know at that stage what can and what can't be done. There's all sorts of advances. Having a stroke, there's all sorts of wonderful things that can be done. So we call an ambulance. The ambulance has no discretionary power. So you're taken to the local emergency department, and their goal is to package. They're told that they have to get everything done within 4 hours, otherwise they're punished. So it's easier to bring them into hospital than to make all the phone calls and have all of the discussions with family about alternative ways of doing things. And then they come into the hospital, and then they come into my intensive care unit. So, as I said before, the whole dying process has been medicalised. It's a conveyor belt, and it's very difficult to pluck people off the conveyor belt. And it's very difficult for you to pluck yourselves off a conveyor belt, because doctors will give you hope, and that's their job, to give you hope. But sometimes they give you unrealistic hope. Some of the drivers, dying's frightening. There's lack of community alternative ways of supporting dying, so it's easier to come into a hospital. Societal expectations. Every day, even in really good media, we're hearing about the latest miracle, drug, intervention, or whatever. Uncertainty is a part of medicine. It's just a part of medicine. And so people prey on the uncertainty. Oh, well, there's a small hope. There could be a miracle. We want that hope. Because we can do things, we do things, and of course there's fear of litigation. I like this. I've only read this recently, but in 1973, Ernest Becker said that all human actions are taken to ignore or avoid the inevitability of dying and death. I don't know whether that's true, but there is there is an element. Now, what I'm going to talk about is not just death and dying. I'm going to talk about aging. Now, I know that there's an issue with this, and I know that it's pornographic to talk about death and dying, but it's even less acceptable to talk about aging, because it's something that all of us are approaching or going through, and we like to put it to one side. But these things are linked, and I'll try to tell you why. There's this wonderful concept of apoptosis, where at the time of conception, the death of all of your cells are encoded. So at that time, we know when your skin's going to start to become wrinkly, when your bones are starting to become demineralized, when your muscle bulk becomes less, your kidney, brain, liver, heart function, all of these things are encoded. You're only meant to be born and reproduce and then die. That's how we evolve. That's the way the system works. But now with modern medicine, we can take you up to your apoptotic potential. So if everything's meant to fall apart at 92, that's fine. We can get you there now, unless you get hit by a bus or something like that. In intensive care, I can take you past your apoptotic potential. I can put you on machines and take you up to 93, 94. You won't know anything about it, but there you go. I've got that potential. But so it's a built-in obsolescence. It's similar to my printer and my computer. There's a built-in obsolescence. You've got to buy a new one because they don't work, or they break down, or all the new things don't fit into it. So we also need to be talking about aging. Sorry. Nelson Mandela, you'll hear on the news, has been admitted to a hospital's intensive care unit with a lung infection. He is in a critical condition. I work in intensive care. I don't know what critical means. I never have. I think it means really bad. But I don't know what serious and critical mean. But it must be bad because he's on life support. Nelson Mandela hasn't got a lung infection. He is dying of old age and frailty. Of all the people in the world who has the courage, acceptance, and dignity to face this, it must be Nelson Mandela. But they're not telling him that, and he's just accepting, trusting the doctors who are putting him on these machines, and that's the same with our society. We do these things without being honest and explicit. So as we get older, we get reduced muscle strength, bulk, brittle bones, and all of these things that I discussed. And this is what our patients look like today. They've got what we call comorbidities, which is a medical term, usually meaning the things that happen as you get older. And you know, when I heard Andrew's father fell over and you know, like he almost certainly broke his hip. Well, that's what happens when you get older. It's an awful thing and an awful way to die as well. So aging and dying are as a result of the body's function decreasing, becoming frailer. And I like this term frailty. and we're trying to put a little bit of science around it. Instead of being obsessed with diagnoses, we're sort of moving to this concept of frailty, and there are ways of defining it, which I won't go into today. Dying in acute hospitals, a myth. Hospitals are good places to die. They are not good places to die. All of the evidence suggests that they are dreadful places to die. They're not geared up to dying. They don't know how to diagnose dying, let alone how to manage it properly. A myth, doctors know how to diagnose dying and understand the limits of modern medicine. They don't. And I used to get very frustrated with my colleagues until I sort of thought one day that I work in intensive care, they send sick people to me, and some of them get better and I send back. But they don't know my specialty. So therefore they're asking me really to make the diagnosis of dying. So I'm sort of coming to terms with that responsibility that I have. Gawanda, some of you may know this American author. He's a surgeon and he writes very popular medical books. And I was asked to review one of his books, and I found this phrase there which absolutely stunned me. He said this person who he treated 3 months in intensive care, sent home weak and debilitated, lost his business and house, moved in with his sister, but he survived and most don't. And he thought that was a good outcome. I don't believe that was a good outcome. Where to next? End-stage cancer. We all know about palliative care and end-stage cancer. We're beginning to know more about end-stage heart failure and end-stage lung failure and end-stage renal failure and other end stages. But I don't think we're as yet tackling the Nelson Mandela issue of there's an end stage where you become so frail and so old that you can't live any longer. And I think that's probably the next stage. Expanding palliative care, this is essential. It's about empowering nursing staff, medical staff, the whole palliative care team, moving them to centre stage. Palliative care at the moment is on the edge of medicine. That's the way I see it. They wait for referrals, and I don't believe that should be the case. I believe they're an essential primary specialty. They obviously work very closely with GPs. That all needs to increase so that we've got a patient-centred system for people that are dying. And I believe palliative care have a responsibility to be very noisy and to be advocating at all levels of government for a better way of dying, to empower people to have control over their dying process and to develop integrated, comprehensive systems. So this is the way I see it now, and I'm almost finished, that general practice, I guess the sort of patient they see is a 25-year-old, 24-year-old who's got the flu, had it for 4 days, but not getting better. That's a sort of typical patient. Emergency patients, 50-year-old pedestrian hit by a car, go to emergency. Hospital, 45-year-old for some sort of operation, bowel cancer. The reality is that there's many old patients with multiple age-related comorbidities who are nearing the end of life. That's the patient we have nowadays. Where do they fit here? They really don't fit there at all because of the silo nature of medicine. You know, we sort of talk about diagnosis or this place or that place. We need to build a system around patients who we have nowadays and not ram them into our inappropriate systems. It's win-win. There's unsustainable costs being spent in areas such as mine, in intensive care. Now that's something we don't like to talk about because medicine is free in Australia, and that's good, but it is there. I'm spending an enormous amount of money, and meanwhile there's a trickle to carers and to other people. And it would provide better and more appropriate end-of-life care, cheaper, better. I mean, it just, you know, we have to do things differently than the way we're doing at the moment. And finally, when asked what the most difficult ethical dilemma facing science today, Sir David Attenborough said, how far do you go to preserve an individual life? Stephen Hawkins, who was sitting next to him on the same panel, said, yeah, that's a good one. Thank you.